Hey guys, and welcome to the next chapter of anatomy and mechanics of the vertebral column. So it's just a continuation of my lectures I've been doing on the musculoskeletal system and just following on. So just kind of putting a bit of form and function together today. So let's just start by looking at the trunk and the spinal column, just a little recap of what we've been talking about over the last few weeks. So the vertebral column complex, 24 intricate and complex articulating vertebrae, 31 pairs of spinal nerves, abdominal muscles. Some sections are linked by fascia and tendinous bands, do not attach from bone to bone. Many small intrinsic muscles act on head, vertebral column and the thorax, and we'll talk about these and what they do, and basically a lot of the things they do is assist in spinal stabilisation or respiration. So let's look at the bones themselves. We have 24 articulating and 9 fused vertebrae, 7 cervical in the neck, 12 thoracic in the chest, 5 lumbar in the lower back, 5 sacral, posterior pelvic girdle, and 4 coccygeal in the tailbone. 7, 12, 5, 5, 4 keeps us all standing tall. So the vertebrae increase in size from the cervical to the lumbar region due to the lower back having to support more weight. And you'll remember in my previous lecture I just talked about, or I went through some of the key anatomical features of the vertebra and how weight distribution plays an important point on their overall structure. So, the 3 normal curvatures within the moval spine enable it to absorb blows and shocks, or allow us to distribute weight evenly or functionally. The thoracic spine curves anteriorly. Kyphosis is increased anterior concavity of the thoracic curve. The cervical and lumbar spine curve posteriorly. And as we discussed previously, lordosis, which is the increased posterior concavity of the lumbar and cervical curves, lumbar kyphosis, which is the reduction of normal lordotic curvature, which results in a flat back appearance. Scoliosis, as we watched in one of the previous lectures, is this lateral curvature or sideward deviation of the spine, and as I mentioned previously, this can cause problems internally with some of the organs in the corresponding region. Some of the bones. The first cervical 2 vertebra, we have the atlas C1, axis C2. The vertebra C2 through to L5 are similar in architecture as we discussed. We can just see here some images. We have the transverse processes, the posterior arch and the facet, and superior articulating facets with the occipital condyle. And it's just important just to think how the atlas and the axis communicate with each other, and how overall, thinking about them individually as anatomical or osteological structural forms, but also thinking of how they combine together to form functional movement of the region. Remember that the joint that we're talking about in relation to the atlas and the axis is of course the atlanto-occipital joint. The first joint formed by the occipital condyles of the skull sitting on the articular fossa of the first vertebra, and it allows the capital flexion and extension movement. The atlanto-occipital joint, atlas C1, sits on that of C2, which of course is the axis, and most cervical rotation occurs here. So we've got a good degree of rotational movement. Around 50% of total cervical rotation is at this point. So the cervical vertebra C through to C7, the body of all the vertebrae, bifid. So bifid spinous processes, as we talked about in the previous video, transverse foramen for the vertebral artery, and 5 to 7 degrees of rotation each is about 50% of total cervical rotation. So as I mentioned before, there's a good degree of movement within the cervical region as opposed to the next bit that we're going to talk about, which is the thoracic vertebra, which of course is T1 through to T12. The thoracic vertebra articulate with the ribs, as we mentioned in the previous lecture. The costal facets articulate with the ribs themselves, and the characteristics are these down-sloping spinous processes that we can see when looking at the full skeleton. As we move on to the lumbar vertebra, L1 to 5, we can see that the bodies of the vertebrae are the largest to support the weight bearing, and as I've been kind of going through these lectures over the last few weeks, I've really been talking about weight distribution and weight bearing, and these lower lumbar bodies being, kind of bulky, looking rather blown up, as it were, as opposed to the others. Thick, bulbous spinous and transverse processes, and there's not really any wonder because they've got all of that weight distribution from the upper trunk. So let's just look at the articulation of the ribs with the vertebral column. So there's 12 pairs of ribs, 7 pairs of true ribs attached directly onto the sternum itself, which we can see here, and the 5 pairs of false ribs, 3 attached indirectly to the sternum, and 2 pairs of floating ribs, which the ends are free, which we can just see down here. We can see these floating ribs, and then we can just see this communication of the other ribs and how. So we've got the sternum here anteriorly, the manubrium, the body of the sternum or the sternal angle here communicating the manubrium and the body, and the xiphoid process and the xiphisternal joint. And we can just see how the first rib, second rib, third rib, etc. just communicate all the way down, right down to 10, which kind of communicates alongside these other ribs, but not directly, as it were, because we've got this costal region, which you'll remember is important, because if the entirety of the rib cage was formed from dense bone material, it would be impossible for respiration to occur. So it's good just to kind of look back and think of what's bone, what's bone tissue and what's cartilaginous material and why. It's kind of bringing structure and function together. So let's just recap on some things that we talked about briefly. The IVDs, or the intervertebral discs, they are between and adhering to the articular cartilage of the vertebral bodies. We mentioned the annulus fibrosus, the outer rim, and of course the nucleus pulposus. We talked about some of the compression issues, such as with spondylitis, and some of the other problems that we see with disc herniations, whether it be unilateral or bilateral compression on nerve roots, and some of the symptoms that you may see with people who have some injuries relating to this. So herniated nucleus pulposus, herniated or slipped disc, is a nucleus protruding through the annulus, and it's resulting from substantial weakening combined with compression. And you can just kind of see in this picture that I've got here, you've got the pressure coming from superior down to inferior on the vertebral body, compressing on the herniated disc. That herniated disc is herniating posteriorly, compressing on the spinal cord. As I mentioned, this could be a bilateral or unilateral spinal cord nerve root damage. So this is going to present. You may have somebody who has right-sided shooting pain or numbness or mechanical deficit, or it may be bilateral, suggesting that this herniation is compressing the entirety of the spinal cord itself. So it's important just to kind of picture that in one's mind. So the protrusion puts pressure on the spinal nerve root, and then this causes, as I mentioned, things like radiating pain, tingling, numbness, or weakness in some of the lower extremities. Let's just look at some of the movements that we have. So we've got spinal flexion, so the anterior movement of the spine in the cervical region, the head moves towards the chest. In lumbar region, and the thorax moves towards the pelvis. So we have the flexion extension of the neck, flexion extension of the trunk or the upper trunk, flexion extension of the abdominal region, and of course, flexion extension of the upper and lower limbs, which we'll talk about when we start to look at some of the plexi which are responsible for these movements. Spinal extension, it's return from flexion or posterior movements of the spine. In cervical spine, head moves away from the chest and thorax moves away from the pelvis. So we can, I'll just go back there. So you can see capital extension, lumbar extension. And you'll remember, as I mentioned in my previous lecture, kyphosis, lordosis, scoliosis, lordosis, this lumbar movement, so this lumbar extension kind of forming this almost sort of artificial lordotic look, as opposed to the kyphotic look that, as I mentioned, we see in elderly with the presentation of things such as Dowager's hump. Lateral flexion, cervical lateral flexion to the right. In the image we can see lumbar lateral flexion to the right, sometimes referred to as side-to-side bending. Reduction, return movement from lateral flexion to neutral. Spinal rotation, this left to right turning, cervical rotation to the right, as we can see, and lumbar rotation to the right. The rotary movement of the spine in the horizontal plane, chin rotates from the neutral towards the shoulder and thorax rotates to one side. So let's start to have a look at some of the trunk and spinal column muscles. So the abdominal wall muscles do not go from bone to bone, but they actually attach to an aponeurosis, which is a fascia around the rectus abdominis area. We have the external oblique abdominal, internal oblique abdominal, and the transversus abdominis or transverse abdominal muscle. So if we just kind of go through, we can sort of have a look at this kind of intermediate and deeper layer of muscles. So we can see as we go further up into the thoracic region, we have the serratus anterior, then the linea alba down into the actual abdominal region, linea alba being the white line, you'll remember from your anatomy classes. You've got the rectus abdominis here. You can see the muscle fibres going in this downwards motion. This is the rectus abdominis. Now the rectus abdominis is covered by this rectus sheath, so it's just kind of covered over, and then in the cadaver, as you sort of dissect through, you can kind of make an incision through this rectus sheath and then retract it medially or laterally, and then see these nice muscle striations going down. On the lateral aspect, we have these oblique muscles where we can see the external oblique, and then we've got this kind of three-layer dissection. You've got the internal oblique. So the external oblique, you can see the fibres kind of traversing downwards like this. Then the next layer, you've got the internal oblique, and then the transversus abdominis or transverse abdominis. We're not going to talk about this today, but these three layers are important when we talk about something called the deep and superficial inguinal ring. And it really does make sense once we start to look at that, and when we talk about the deep and superficial inguinal ring in relation to these three layers of muscles and then the aponeurotic layers that they then convey, which essentially form these rings, these important rings, which we'll talk about when we come to that section. So the muscles of abdominal wall: rectus abdominis, external oblique, internal oblique, and the transverse abdominis. Just some more images here. So we've got the rectus abdominis, external oblique, internal and transverse, but in this dissection, or in this image, what we can see is the rectus has been cut through and moved away, and then what you've got is the posterior wall of the rectus sheath. The rectus abdominis is removed, as I've said, but you've got, in essence, when you see the rectus, it's sitting in this sheath anteriorly and posteriorly, and what you'll notice here, there's a little region which isn't covered, and that's another point that we're going to talk about as we go through these videos. Some important points about the internal abdominal wall and the internal abdominal viscera, and how this line is important when it comes to, or is in relation to, the actual rectus itself. And what you can see here is you've got a kind of cross section, and you can see the rectus abdominis muscle here. And then, well, let's start from the outside and look. Well, what have we got here? Well, we've got skin, and then we've got subcutaneous fat, and then we've got the external oblique, internal oblique, and the transverse. Now, what you'll see is the external abdominal, external oblique gives rise to this aponeurosis of the external, and you can just kind of track that down and follow it to where it forms with the linea alba. Then you've got the internal oblique with the same thing. You've got the aponeurosis following around, and then kind of splitting into two, and then wrapping around like a kind of sandwich, as it were, over the anterior and the posterior surface of the rectus. Then you've got the transverse abdominis, which is running and giving off an aponeurosis, which is very much giving rise to a posterior sheath. Now, the difference is above and below this important point, where the posterior wall kind of disappears, as it were, below this point, which just bear that in mind, because we will be covering that in the next few sessions. So the rectus abdominis muscle, both sides, responsible for both sides lumbar flexion, posterior pelvic rotation, right side weak lateral flexion to the right, left side weak lateral flexion to the left, and you can just see the origin and the insertion of the actual abdominis muscle itself. So the cartilage of the 5th, 6th and 7th ribs and the xiphoid process just kind of wrapping around and then attaching down at the crest of the pubis. So you've got this just wrapping itself along from top to bottom. And you can just see lateral flexion, and these tenderness insertion as points, which give people that classic 6-pack look, or in some cases an 8-pack, as it were, depending on the pyramidalis muscle at the inferior border as well. The external oblique abdominal muscles, so both sides lumbar flexion, posterior pelvic rotation, right side lumbar lateral flexion to the right, rotation to the left, and lateral pelvic rotation to the left. The left side lumbar lateral flexion to the left, rotation to the right, and lateral pelvic rotation to the right. And you can just see again these origins and these insertions, all the borders of the lower 8 ribs at the side of the chest deviating with serratus anterior, and then you can see the anterior half of the crest of the ilium, inguinal ligament, crest of the pubis, fascia of the rectus. So you've got this, this good covering. You can see the kind of origin and insertion points on this diagram on the left, and then where the actual external muscle goes. And remember, you've got this build-up within the obliques of the external, internal, and the transversus. The internal, you can see the difference in the actual striations of the muscles as opposed to the external, which were running downwards. The internal is running up. The movements, both side lumbar flexion, posterior pelvic rotation. You have right side, which is lumbar lateral flexion to the right, rotation to the right, and lateral pelvic rotation to the left. You have the left side, which is lumbar lateral flexion to the left, rotation to the left, and lateral pelvic rotation to the right. The transverse, oh dear, let me just try and get this working. Transverse abdominis muscle, forced expiration by pulling the abdominal wall inward. So you can see, as opposed to the external and the internal, the transverse, you just got this transverse muscle striation. And a good way of thinking of muscles is think about their origin, think about their insertion, then think about their action. Origin, insertion, action. If you think about the origin and the insertion of, say, the bicep, when you pull upon where the insertion is, you flex your bicep. And the same can be done with any muscle in the body. If you're confused about the action, just think, pronator quadratus, supinator. It supinates, it pronates, origin, insertion, pronation, origin, insertion, supination. It's the same with all of these muscles and muscle layers. So forced expiration by pulling the abdominal wall inward. Transverse abdominalis also stabilizes the lumbar spine in conjunction with the erectus spinae group of muscles. The quadratus lumborum muscle, lateral flexion to the ipsilateral side, it stabilizes the pelvis and the lumbar spine. Extension of the lumbar spine, anterior pelvic rotation, lateral pelvic rotation to the contralateral side, and you can just see the origin insertion again. You've got the 12th rib coming along these transverse processes. You have the iliac fossa here, and then this upper border attaching here, the posterior inner lip of the iliac crest. So some muscles that move the head, well, they all originate on the cervical vertebrae and insert onto the occipital bone of the skull, the capitis. Three anterior vertebral muscles, longus capitis, rectus capitis anterior, and rectus capitis lateralis. All are flexors of the head and upper cervical spine. Rectus capitis lateralis laterally flexes the head, assists rectus capitis anterior in stabilizing the atlanto-occipital joint. Some other muscles that move the head, posterior muscles, we have the rectus capitis posterior major and minor, oblique capitis superior and inferior, and the semispinalis capitis. All of these are extensors of the head except the oblique capitis inferior, which rotates the atlas. Obliquus capitis superior assists rectus capitis lateralis in lateral flexion of the head. Rectus capitis posterior major rotates the head to ipsilateral side. Semispinalis capitis rotates the head in contralateral, to the contralateral side. Upper trapezius extends the head and rotates it to the ipsilateral side. So it's just important just to think not only individually of how these muscles work, but how they work in conjunction with each other and as a whole. So we've just got the just go back. We've got some of the posterior muscle groups that we can see in this deep and superficial dissection. We've got the semispinalis capitis in this image here, the splenius capitis, the sternocleidomastoid muscle, the vata scapula, splenius cervicus, serratus posterior superior, rhomboideus, which we've got cut, rhomboideus major, and then these deep muscles that we've just talked about, the rectus capitis posterior minor, rectus capitis posterior major, obliquus capitis superior, obliquus capitis inferior. Then we have, as we sort of traverse downwards, longus capitis, splenius cervicus, which we've got retracted laterally, levator scapular, retracted laterally, scalenus medius and scalenus posterior. Then we have, as we sort of traverse more inward or medially, we've got the longus cervicus, iliocostalis cervicus, and longus thoracicus. The sternocleidomastoid muscle, which I started to talk about in my first lecture, where I talked about torticollis, or the shortening or rotation of the head due to torticollis, both sides extension of the head at the atlanto-occipital joint and flexion of the neck, right side rotation to the left and lateral flexion to the right, left side rotation to the right and lateral flexion to the left. So we can see that the sternocleidomastoid muscle itself, we have the clavicular head and the sternal head, and you can see the rotation, the lateral flexion to the left, the mastoid process, the attachment point. Okay, splenius muscles, cervicus capitis, so both sides extension of the head, splenius capitis and neck splenius capitis, and the right side rotation and lateral flexion, left side rotation and lateral flexion to the left. The transverse processes of the cervical 3 vertebra, again we can see these origins and insertions, the spinal processes of the 3rd through to the 6th thoracic vertebra. And as I said earlier, it's really kind of helpful to think where the origin is and where the origin is and where the insertion is, because if we know where the origin is and we know where the insertion is, we can then equate what the actual movement will be by tugging, as it were, on the origin. Muscles that move the head. So notice the anterior cervical spine has much less muscular development as opposed to the posterior, but we do have some important groups. We have the suprahyoid group, the infrahyoid group, which we can see marked here on these two opposing diagrams. I'm not going to go through all of these with you now, but it's important to break these regions down into the anterior, posterior triangles, the carotid triangles, clavicular triangles, etc., which we will cover in a different session. Posterior muscles of the thorax involved almost entirely in respiration. The diaphragm itself is responsible for breathing during quiet rest. As it contracts and flattens, thoracic volume is increased and air is inspired to equalize the pressure. When large amounts of air are needed, as in exercise, other thoracic muscles have a more significant role in inspiration. The posterior muscles of the thorax, the scalene muscles, elevate the first 2 ribs to increase the thoracic volume. Scalenus anterior, medius and posterior. And these are also an important point. So you can see sternocleidomastoid, you can see the scalene muscles, and then the border between scalenus anterior and the scalenus medius is an important point, because this is where we're actually going to see the brachial plexus coming out. So it's good just to remember the point between scalenus anterior and medius. The external intercostals further expand the chest. The levator costralis and serratus posterior play a role within inspiration. The internal intercostals from transverse thoracicus and subcostalis contract to force expiration. The erector spinae muscles, of course, iliocostalis, longissimus and spinalis. The ILS muscles, or if you want to play it backwards, the SLI muscles, iliocostalis lateral there, longissimus middle there, spinalis medial there. All of these forming the erector spinae. extension, lateral flexion and ipsilateral rotation of the spine and head, and anterior pelvic rotation, lateral pelvic rotation to contralateral side. Deep muscles of the vertebral column, we have the posterior interspinal intertransverse group, intertransversale muscle, flex vertebral column laterally, connected transverse processes of adjacent vertebrae, and we can just see alongside we've got the intertransversale, the slime muscle, spinalis longissimus, iliocostalis, quadratus lumborum. We have multifidus, the lumbar portion. As we go up further, we can see on the more superficial splenius capitis, which we discussed briefly earlier, the semispinalis, the levator scapular muscle, which is cut away, which of course is going to communicate with the scapula and can then form on to the rest of the shoulder joint. Deep muscles of the vertebral column, muscles that play a major role in stabilizing the spine. Multifidi is a major spinal stabilizer. Segmental innervation, spinal segment misalignment inhibits this muscle. Works in conjunction with the abdominal muscles, especially transverse abdominis. This is a really important point, and this is often one that's missed out in teaching and even in clinical practice as well. It's really important to remember agonist and antagonist muscle groups. Flexors work with extensors, extensors work with flexors. Muscles act upon each other. If one goes to the gym and works abs every day, constantly, you're going to move into a degree of flexion. If you work the back constantly, constant extension, you're going to move into a constant extension with the rectus muscles being pulled into a kind of elongated state. So the flexors and extensors have to be worked in contrast with each other. So lots of movement dysfunction, movement disorder, lots of abnormal postures can be seen when movements are performed on a repetitive nature, such as when sat at a computer with the neck in the kind of swan position. Craning of the neck causes this kind of over-exaggeration, depending on how you may be over-flexed or over-extended, depending on how you're sitting. Overwork of one muscle group can cause the opposing muscle to be pulled upon. For instance, really common, guys go to the gym, work out the chest, work out the pec, and their kind of whole shoulder girdle becomes like entrenched in this kind of medial rotation movement, and the back becomes kind of sprayed out, as it were, splayed out, and you see the shoulders kind of sort of medially rotating on the anterior border. Okay guys, that's it for today. Thank you again for watching my anatomy review. Please send me some feedback if you have any questions, if there's any topics that you would like covering, if there's anything that you would like to explore in more detail. I'm going to aim to try and cover the MSK lectures in maybe 5 or 6 PowerPoint presentations. I'm also going to do some interactive classes and film those and then post those as well. And I've got some 3D models which in my 3D shareable library that you can download and use as you see fit. And thank you very much.